Tracheoesophageal fistula, or TEF, is a congenital or acquired abnormal connection between the trachea and esophagus. It's a rare but critical condition that often presents in neonates, though adult-onset TEF can occur secondary to trauma, malignancy, or infection. Prompt diagnosis and management are essential due to the risk of severe respiratory and gastrointestinal complications. TEF is most commonly classified by the Gross classification, which includes 5 types. Type C, most common esophageal atresia with a distal fistula. The proximal esophagus ends blindly, and a fistula connects the trachea and distal esophagus. Type A, pure esophageal atresia without any fistula. Type B, esophageal atresia with a proximal fistula to the trachea. Type D, a rare variant with both proximal and distal fistulas. Type E, H-type tracheoesophageal fistula without esophageal atresia, typically presenting later in life due to less severe symptoms. Each type presents distinct challenges in diagnosis and management, with radiological and endoscopic evaluation playing crucial roles in identifying the fistula's location and severity. Early diagnosis of TEF is vital, especially in neonates. Initial signs include drooling, inability to swallow, and respiratory distress after feeding. Diagnostic steps include prenatal ultrasonography. Polyhydramnios or absent stomach bubble can raise suspicion of TEF. Postnatal investigations, insertion of a nasogastric tube and X-ray confirmation can help detect esophageal atresia, while contrast studies and bronchoscopy may be needed to locate the fistula in more complex cases. Before surgery, stabilizing the patient is crucial, with steps such as preventing aspiration by keeping the baby in a head-elevated position and administering intravenous fluids. Definitive management is surgical, typically within the first few days of life for neonates. Several techniques can be employed based on the type of TEF, primary anastomosis, and type C TEF. Surgery involves ligating the fistula and performing a primary anastomosis of the esophageal ends. This is usually done via a right thoracotomy or thoracoscopic approach, depending on surgeon expertise. Esophageal substitution, in cases where the esophageal gap is too wide, e.g., long gap esophageal atresia, delayed repair or esophageal substitution may be required using a gastric pull-up or colonic interposition. Postoperative care and complications. After surgery, neonates are monitored for complications such as anastomotic leaks, stricture formation, and recurrent fistula formation. Long-term follow-up is required, especially for complications like gastroesophageal reflux, tracheomalacia, and respiratory issues. In adult-onset TEF, management depends on the underlying cause. Malignant TEF requires palliative stenting, while benign causes may allow for primary repair. Advances in minimally invasive surgery, particularly thoracoscopic repair, are offering improved outcomes in terms of reduced recovery time and postoperative complications. Additionally, new techniques like tissue engineering for esophageal regeneration are being explored, though these are still in the experimental stages. Current research also emphasizes enhanced recovery protocols post-surgery, which focus on earlier enteral feeding, reducing hospital stays, and minimizing ventilator dependency. In conclusion, while tracheoesophageal fistula remains a complex condition with potential long-term complications, early diagnosis and advances in surgical techniques have significantly improved patient outcomes. Multidisciplinary care, involving neonatologists, surgeons, and gastroenterologists, plays a critical role in optimizing both surgical success and quality of life for TEF patients.